Hey class,
Ruby and I are going to talk about our ventilator patients.
Phoebe's gonna go first.
So, for my ventilator case study, my patient is a 36-year-old female. She had her surgery done at Mayo Clinic. So, she was admitted due to transplant complications. Why did she need a lung transplant? So, she was diagnosed with BPD, which we all know is overexposure to oxygen as a baby. Um, Her first lung transplant was done in 2014 at Duke University Hospital. Why did she need another transplant? So she developed complications from her first transplant. She was treated for refractory rejection with ATG, which is anti-thymocyte globulin. It's an anti-human T lymphocyte derived from horses and rabbits. It's an immunosuppressant drug that helps reduce the production of inflammatory cytokines. So her second lung transplant was done at Mayo on May 1st, 2023. During her first lung transplant, and the reason for her second one is because she also developed CMV, which is cytomegalovirus. It's an infection that occurs due to the reactivation of a latent infection in the transplanted lung. She also developed leukopenia and renal insufficiency. And she had advanced BOS, which is bronchiolitis obliterans syndrome. It's a progressive airflow obstruction, and there's 4 different levels of it, 0 through 3, and 3 being the most severe. It's based off your FEV1. So a 3 is an FEV1 of less than 50%, which is what she had. So in 2020, she was evaluated for a lung transplant, but they determined that it was too soon. And then in 2022, she was evaluated again, and she was placed on the list in January, but she was removed because she was positive for COVID-19. In February of 2022, she continued to test positive for COVID-19, so they kept her off the list. In March, she finally had 2 consecutive COVID-19 tests that were negative, and she was able to get put back on the transplant list. So her pre-op assessment, her vital signs were good. Her breath sounds, she had bilateral wheezing. Her CBCs were okay and stable. Her CT of her chest showed mild bronchiectasis in the lower lobes, as well as mild fibrosis in the upper lobes. Her chest x-ray showed hyperinflation of the lung fields bilaterally, which we all know that's how BPD presents initially, and because of her CMV and her BOS score, it presents the same way. Her EBGs were a pH of 7.45, a CO2 of 29.2, and an O2 of 85.8 on room air. So complications in the OR. This lady had been put through the ringer during her surgery. First, there was a donor-recipient mismatch, which resulted in a bilateral upper lobectomy. They ended up having to do a wedge resection in her right middle lobe, which left her with part of her right middle lobe, her right lower lobe, and just her left lower lobe. When they went in to do the surgery, they had to remove the sternotomy wires from her first transplant, and her chest wall and her sternum were so fragile that when they went to go remove them, her sternum fractured. A lot of trauma and a lot of bleeding. She ended up getting 30 units of blood as well as blood products. They ended up placing her on ECMO, VV ECMO, because of her low lung compliance, the amount of trauma due to her lungs, and the blood loss. They couldn't close her chest, so she ended up on the unit initially with an open chest. So her post-op vital signs. Her vitals were okay considering, although her CVP was 13, which is pretty high because 2 to 6 is normal. Her mean pulmonary artery pressure was a little elevated, 39/19. Her x-ray showed bilateral diffuse infiltrates. Her vent settings were pressure control ventilation of 15, FiO2 of 50%, a PEEP of 10, a rate of 10. Her exhale tidal volume was 182 to 233, which is, considering how much lung she has left, seems appropriate, but for any normal person, that's super low. Her minute ventilation was only 1.87. Her ECMO settings were 3.55 liters per minute, 2,600 RPM, a sweep of 2, and an FDO2 of 100%. Her ABGs were a pH of 7.33, a CO2 of 45, a bicarb of 24, and an O2 of 112 on 50%. So the day after surgery, she had even more complications. She continued to bleed significantly and developed symptoms of cardiac tamponade. They took her to the OR and removed large blood clots from her lungs. After they did that, her vital signs, her urine output, her lung compliance, and her tidal volume improved greatly. Throughout the month of July, they slowly started titrating her ECMO and her settings, and she ended up getting trached within that time. July 22nd, she was finally decannulated from ECMO. She had a conversation with the doctors, and her fiance was there, and they basically told her that she could not be placed on ECMO again because there's no end game for it. They feel like if they put her back on ECMO, then her quality of life would be extremely poor. Other reasons why they wouldn't place her back on ECMO is the damage done to her arteries were too great. She also isn't a candidate for another lung transplant because every time they do a lung transplant, they cut the trachea, and she doesn't have enough of it to attach new lungs to. The medications that she's on is amphotericin B, 20 milligram nebulizer solution twice a day. That is an antifungal medication. It's the most commonly used antifungal medication prophylactically for lung transplants. She's also on colomiacin 75 milligrams BID, which is an antibiotic for long-term lung infections. She's also on Atrovent, which we all know is an anticholinergic, and Xopenex, which is a bronchodilator. There's 2 days that I had with her that stick out the most. One of them was one of my last clinical days. They were concerned because she was showing signs of delirium and confusion. And the team thought it was medication, so they were like discontinuing some and titrating others, but it wasn't getting any better, so they wanted to take her to CT to get a CT of her head.
I thought it was meds.
I think it was initially, but just to rule anything out. So we took her to CT. She wasn't very compliant with being in the machine. She kept moving her arms, attempting to pull lines. So it took us like 3 attempts to finally get a good CT of her head. And then when we took her back and got her stabilized and good to go in her room, we let her settle down for a little bit, and then we came back to do her trach treatment, and she was refusing. She didn't want anything done. We had to kind of, coax and compromise to at least let her get us to change her inner cannula. When I was changing her inner cannula, I was in the middle of swapping it, and she attempted to bite my hand. I had to tell her, we don't bite. Biting's bad. I finally swapped it real quick and hooked her back up to her ventilator, and as soon as I hooked her up, she discontinued it. Or disconnected it. Yeah, immediately. She seemed very kind of depressed, like she's kind of over it. I mean, she's been in the hospital now over 100 days. She's been there since the end of April, and it's, the end of August. So that was a pretty tough day for her. I came back a few days later, so I think this was like a Thursday, and then when we came back for our Monday clinicals, she was doing a lot better. She seemed more active in her care, asking questions, kind of joking around. She has sunshine privileges, which allows patients to leave the unit. And at Mayo, they have like this atrium that's all windows, and then outside is like a waterfall, and it's very pretty. So we took her down there for about 15 minutes to kind of get her some sun and out of her room, and took her through the gift shop for a little bit, and she kind of looked at like the earrings and all the cat stuff. She's a very big cat person. And I feel like she's been improving a little bit since then as far as like her attitude.
Yeah.
I don't think she's had any other bad days since then that I can recall. I try to check on her occasionally since, you know, we're at Mayo for work during the weekends. So like I said earlier, she can't be put back on ECMO because there's no end game. Her quality of life won't be great, and the trauma and deterioration of her arteries. And she can't get another transplant. She's bed dependent, so really the best chance that she has is to try to get out of the hospital, and hopefully, you know, somebody will help take care of her, or a long-term care facility.
Yeah, I think that's the next step, is
The
looking for
long-term
somewhere
care.
to take her.
Yeah, but she's never going to come off her bed, unfortunately. It's very sad. She's very sweet. She's super young. I think she was a teacher. I think. And yeah, it's just sad. Something that could have been prevented when she was little, BPD, is what got her in her situation now. So, the end. Thank you.
Okay, so now it's my turn.
I like that title. Toxic.
Oh, I guess I should put it over. So Jamie's and I's patients are both ones that we both help throughout our clinicals, and then like she mentioned, we're both working at Mayo, so we both have knowledge of these patients. And my patient specifically, we both attended to her first day that she was in the hospital. I called her the happy hypoxic, actually from Mr. B, because he actually stated there are patients that live in a chronic hypoxic state that you wouldn't imagine because they're always in a good mood and willing to talk and living what seems like a normal lifestyle. The initial encounter, this patient came through the ED, came through with shortness of breath and tightness in her chest, and was just wanting to come through to get some treatment for that. She came in, and when we saw her, she was sitting in the low 80s on a 10-liter oxy mask and was getting treatments back to back. I believe there were geonebs that she was receiving back to back, and she was actually joking around with the two of us.
Yeah, she was.
Just like happy as can be, just, you know, laying there and just. And she was like, just didn't seem right, you know, and I remember like questioning if like the monitor was right, but it was. So her background ends up that she is a patient that has COPD. She also has cor pulmonale and pulmonary hypertension, and she lived at home with 4 to 5 liters of oxygen, and mentioned to us that she would live in a state of having a saturation like in the high 80s, like 86 to 88 was her norm, and that's how she just lived at home. And initially, our first goals in the ED were try to, you know, treat her tightness and her shortness of breath with bronchodilators, and increase her SpO2. Even though she had like 3 or 4 treatments back to back, it didn't really make a difference. We listened to her, and you heard no air movement. Like, you could notice the barrel chest, but there was no movement at all whatsoever. Like, it sounded like just nothing. And I remember like using my scope, and I was like, something's wrong. And I actually asked Jamie for hers, so I thought mine weren't working. But they were like, no, she just is that tight that nothing is moving. We switched from the oxy mask to the high flow nasal cannula. I believe we were on 60%, 50 liters initially, and she went up to possibly about like 92, 93. Yeah, low 90s was what it was. And that was her first day, kind of got her settled, and then saw her again the next day with a different assignment. And then by that time, she already used the BiPAP at home at night, and so they tried to mimic that, obviously, and she was on a BiPAP throughout the night, and then the next day as well. We saw her early the morning the next day, and we were trying to see if we could wean her and take her off of the BiPAP and put her on a different device, but sadly that didn't work. We took it off, tried a nasal cannula, instantly started dropping, turned that up, that didn't work, switched it out back to the oxy mask, that didn't work. So we put her back on the BiPAP and then went back to grab the high flow to see if we could do that again. So tried that, and then that didn't work either. And in between these breaks, she's just like,
I'm hungry.
I want to eat. I want to eat. Like, she's like, oh, all right, fine, put it on, blah, blah. Like, she's just, but in a, overall, like in a good mood, just talking to you. And you just figure that somebody in this state would just not be like that responsive or that alert or like that, just willing to have conversation with you. So the BiPAP ends up that second day, we just could not get her at a good, a good number. And we were just like, okay, she's going to have to stay on it throughout the day. The team was notified. They still were just going to try to keep her on it throughout the day, give her some breaks if needed, but maintain her in that way. So she was still able to take it off for medication and for food breaks. But in those moments that mask would come off, it would still be like starting to plummet. Like we were both on the floor and heard the alarm going off and went by, and like they had taken off her mask to just give her meds, and it was like
high 60s.
Yeah, 60s the sats, and it was like in a matter of like you're watching the monitor and it's just dropping. Like it was so unreal. So we were able to be with her like her first 2 days of admission, and then obviously a few days went by and they're trying to figure out what's going on. So they diagnosed her with diaphragm paralysis, ARDS, cor pulmonale, and chronic respiratory failure. So I was just going to go through and give you little bits and pieces of each one. So diaphragm paralysis, according to Columbia, a surgery organization, typically is caused by damage to the phrenic nerve or cervical spine. Most of the time, 50% of it is actually idiopathic, which means it has no unknown like cause behind it. It just kind of happens. Leads to inadequate gas exchange and then trouble with oxygenation. It's usually diagnosed with x-rays, MRIs, and ultrasounds. The treatment for it is, surgery. Our next one, ARDS, which we have heard a lot about, acute respiratory distress syndrome. This references the National Institute of Health. The condition develops by other disease states or illnesses affecting the alveoli and prevents oxygen to diffuse into the blood and body. Into the lung tissue. It causes scarring. Typically this is, you diagnose it with like x-rays. You also do a lot of ABGs, and you have treatment of, FiO2, and then we talk about mechanical ventilation all the time. And then main treatment for it is just to support the body until it has time to heal. Cor pulmonale, which is right-sided heart failure. This reference is from Cleveland Clinic. It's failure of the right ventricle due to high back pressures. Can be acute or chronic, and then typically this is seen in patients that have COPD, and this is considered a chronic state with them. Our next one, chronic respiratory failure, according to Baptist Health, is a condition where lungs cannot get enough oxygen due to blood or elimination of CO2. High-risk patients are ones with COPD. So the areas of focus, the hypoxemia, when this patient had an episode of shortness of breath and desaturation, it was then executed to intubate and transfer her to the ICU. With intubation, the patient began to produce thick, purulent secretions. Antibiotics began once a confirmation of a sputum sample returned, and the patient regimen for pulmonary hypertension and medications were continued. So even though she had a lot of these health conditions, she did have medications that she was supposed to take at home for her COPD, for her exacerbations, and for her hypertension, but she wasn't compliant with any of them. It would just be like sporadically, here and there, and I think it just all started, getting worse and worse, and it's just like to this point of like having a hard time to get back. We all talk about how difficult it is to wean patients that, you know, are COPDers and that get put on a vent. She was put on some settings. She was on assist control with a rate of 15. Her tidal one was 435. She had a PEEP of 20 was her initial setting. Yeah, PEEP of 20. And then her oxygen requirements were between 70 to 100%. And they were kind of just weaning that as needed. I remember with her being on the vent, she had a very acidic ABG, but the PO2, I won't forget, was like 44. And the doc that day was like, she had a line in and the nurse drew it and then we ran it. And the RT was like, this can't be right. Like, this doesn't look right. We showed it to the doc, and the doc's like, that can't be right. We're like, this is like, something's up. And even though she had a line in, they were like, we need to stick her and like get it true just to make sure nothing happened in between, whatever. Not like they're, it was. It matched, crazy. And it was nuts. But either way, even though she was like vented and had some sedation, when they started taking that off, obviously she was like waking up and she's like, get this out of me. Like, and it's just so weird because like never had I seen her in a point of like distress or like looking like she was bad. Like either way, secretions and all.
Like, agitated was when she was on the BiPAP and like, I'm starving, I want food.
Yeah, and even seeing her intubated, she's like, change the movie. Like, she's like, when are we getting this out? And just talkative like nothing, you know, it just didn't seem to make sense. Well, actually, before we extubated her, that day that I saw her, we did that ABG. The patient, you know, was just adamant of how much she was ready to come off of the vent. Like, she just wanted to come off. And the docs were like, you know, if she fails, she's going to end up being trached. But she's requesting to come off. She's alert and she's with it. Like, we might as well just try. And so they end up extubating her. And long-term goal was just to see if she passed or not. And if not, she would just be re-intubated and then trached if needed. But she was extubated, and not that I know of, she did not have to be re-intubated. They did put her on her BiPAP once we extubated her, and her settings were 17/10, 70%, and a rate of 12. This patient was off sedation, alert, and responsive. Yeah, asking for the removal of the tube, and that's exactly why we ended up doing that. She ended up just being in the ICU for a little bit. I think she was transferred out, but I didn't get much information after that from her. She did not end up re-intubated and just was like in a state of recovery. So my summary is that this patient throughout their journey maintained a positive, talkative persona. I personally remember being confused if we are treating her or the monitor. Textbook knowledge gives us the tools to make our own plan of action. We must tailor to the needs of our patients. So I don't know. I feel like all this stuff in the background made sense for us to treat her, but I don't know if the way that things were done were really the best way. I don't know.
Or, like, if it's somebody's normal, then, you know what I mean?
Yeah, like how do we...
Because, I mean, it's like how we talk about, like, ABGs for COPDers. Like, that's their normal. You can't, like, really improve that.
Yeah.
So...
Yeah.
I guess if that's just how she lives and she's, I mean, fine, she's obviously awake and alert, then did we really treat the patient or did we just treat the monitor?
I know. Yeah. It just was such a strange situation, and just seeing her.
Yeah, that was a crazy case.
Okay. All right. That's what you guys want to do. Yeah. Anyways, thank you guys for tuning into our video.
Thanks for coming to our TED Talk.
All right.
Bye.
Bye. Thank you.